Hello, I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. In this talk, we'll be talking about growth adaptations pathology. Now, you might have noticed that this gentleman on the right has a particular growth adaptation. If you've picked up on it already, I'd give you an A plus for your Gestalt skills. And you probably know what that word means. I'm proud of you. I'm not proud of you if you don't have this book yet, though, because if you want to succeed and do your best in pathology, whether it's in your coursework or on the USMLE Step 1, you got to have this book. So let's talk about growth adaptations. Now, we all know that an organ ideally exists in homeostasis, remember that word for bio 1, homeostasis, with the physiologic stress that it is exposed to. Changes in the amount of stress may result in growth adaptations. This may be an increase in stress or a decrease in stress or a different type of stress. Now we know that an increase in stress causes organs to grow larger. That's why bodybuilders and weightlifters pump iron, right? Get those muscles going, get the pump, increase the stress, grow larger. Whereas a decrease in stress causes an organ to shrink, like our prior friend's right lower leg. We'll see that again. It shrunk because it was undergoing decreased stress, right? It wasn't moving, functioning properly, withered down. A different type of stress may result in a dependent fashion. Here's our friend again, right? Look at his right lower leg. That's due to a preventable condition known as polio. His leg has undergone atrophy, which means to waste away, especially as a result of the degeneration of cells. Atrophy may be due to a decrease in cell size or a decrease in cell number. A decrease in cell size or a decrease in cell number. A decrease in stress may lead to atrophy. For example, a decrease in skeletal muscle size due to the lack of use, like being in a cast, can lead to atrophy. Or say, for example, as a woman advances into her wiser years, when hormonal changes occur and there's decreased estrogen, well, vaginal atrophy may occur after menopause for this very reason. Examples of conditions that may lead to atrophy include the lack of use, like being in a cast, lack of exercise, like a couch potato, lack of hormonal stimulation, like menopause, lack of blood flow due to cholesterol buildup, or lack of nutrients, right? Here's two separate columns showing how a decrease in cell size or a decrease in cell number, I'm dyslexic right now, can lead to atrophy. So a decrease in cell number, that occurs via apoptosis. You remember that? Remember how apoptosis works? Programmed cell death. Ring a bell? Also a decrease in cell size. Now this occurs via the ubiquitin proteasome mediated degradation of the cytoskeleton and autophagy of cellular components. Remember that autophagy of cellular components involves generation of autophagocytic or autophagic vacuoles that fuse with lysosomes that have hydrolytic enzymes that chemically destroy cellular components. You'll remember that. I know you will. I have faith in you. You know what else you'll remember? Hyperplasia. Hyperplasia. Hyperplasia, an increase in cell number. Like this image right here to the right, increase in cell number. Hyperplasia involves producing new cells from stem cells via cell division. Hyperplasia, increase in cell number. More of them. On the flip side, hypertrophy is just bigger. It's an increase in cell size. Hypertrophy occurs when there is an increase in the size of muscle cells. Hyperplasia occurs when there is an increased number of muscle cells. Hypertrophy occurs when genes are activated, proteins are synthesized, and organelles are produced. Hypertrophy and hyperplasia usually occur together, but note that permanent tissues, like neurons, for example, do not make new cells for all intents and purposes. Now, I know there's that one researcher out there who's finally been able to get away from his little bench and saying, oh, well, I did an experiment and I saw a neuron. We're not talking to that guy. We're talking to people who want to do the best on step one, best in their coursework, and remember all the important information so that they can progress, have a great career in medicine. For your purposes, not that PhD who's been working in the lab for 20 plus years who, cloned a neuron that's capable of hyperplasia. Hypertrophy usually is the way that permanent tissues generally grow. Keep in mind that permanent tissues generally do not make new cells. Why am I stressing this? Because it's a common basic question at the medical school level, right? You will be asked the difference between hypertrophy and hyperplasia. It's a basic question. You're going to get it right. Examples of permanent cells include cardiac muscle, skeletal muscle, and nerve. Here on the right, we have a cartoon of some normal cells, hypertrophy, and hyperplasia. If you haven't got it yet, let this image sink in your mind. Hypertrophy, not hyperplasia, hypertrophy occurs in cardiac myocytes in response to systemic hypertension. Hyperplasia can progress to dysplasia and continue to progress to cancer if left unchecked. Endometrial hyperplasia is an example of hyperplasia that may progress to dysplasia. What's dysplasia? We'll talk about it. But first, we need to talk about metaplasia. Metaplasia is the transformation of one differentiated cell type into another differentiated cell type. A change in stress on an organ may cause metaplasia. I'll tell you some examples about this, right? Like Barrett's esophagus due to acid reflux. The cells lining the gastrointestinal tract in that area are like, I don't like this acid. I'm gonna change a little bit. That's metaplasia. Metaplasia most commonly involves changing from one type of surface epithelial cell to another. Examples of surface epithelial cells include squamous cells, right? Squamous cells like your skin. Urothelial cells, right? Like those cells that line your bladder. Or columnar cells, right? Now keep this in mind. Metaplasia is not cancer. Metaplasia is not cancer. Metaplasia may progress to dysplasia. Dysplasia is not cancer. Metaplasia is not cancer. Dysplasia is not cancer. Metaplasia may progress to dysplasia, and dysplasia may progress to cancer. Guess what? Cancer is cancer. Metaplasia is not cancer. Dysplasia is not cancer. Cancer is cancer. We're keeping it real basic, right? These are fundamentals. We're just getting started. Metaplastic cells are better suited to withstand the stress that caused the change in cell type. How does that happen? Well, here's an example. A great H&E histology image showing how the esophagus has been lined with stratified squamous epithelium, but then there's this intestinalized epithelium and stomach with pseudostratified columnar epithelium. This is Barrett's esophagus. Let this image burn into the optic regions of your brain, because you will see this image. I guarantee it. And when you see it, you're going to know that Barrett's esophagus is metaplasia. The classic example of metaplasia is Barrett's esophagus. You know that image. It's in your brain. The esophagus is usually lined by non-keratinized squamous epithelial cells, which are suited to handle the stress and friction associated with swallowing, right? Gastric acid reflux from the stomach can cause metaplasia of the non-keratinized squamous epithelium cells of the esophagus, changing them to non-ciliated columnar cells with interspersed goblet cells, which is the histologic definition of Barrett's esophagus. Metaplasia occurs by reprogramming stem cells to produce the new cell type that can handle the increased stress. Metaplasia is reversible. Metaplasia can be reversed by removing the stress that is causing the metaplastic change, like stopping the GERD, right? Metaplasia of Barrett's esophagus can be reversed by stopping the acid reflux. Continued presence of metaplasia may lead to dysplasia, which can further progress to cancer. The continued presence of metaplasia that causes Barrett's esophagus may progress to dysplasia, which may potentially progress to adenocarcinoma of the esophagus. For all you future ENTs out there, be on the lookout for Barrett's esophagus. Keratomalacia is another example of metaplasia, right? It's another classic form of metaplasia, and it is due to vitamin A deficiency. Who hasn't taken their vitamin A in a while? Have you been eating all your nutrients? Make sure you get some vitamin A so you don't get keratomalacia. Malacia. Pronunciate. Now, vitamin A is needed for the development of specialized epithelial cells, such as the conjunctival surface covering the eyes, right? You want to see your vitamin A. This reminds me of my father. He used to tell me stories about how he couldn't see at night. I don't think he was taking his vitamin A. I'll talk to him about that. Vitamin A deficiency causes thin conjunctival epithelium to undergo metaplasia into stratifying keratinizing squamous cells, which is known as keratomalacia. Keratomalacia. Myositis ossificans is another type of metaplasia, which occurs in connective tissue, and it can also undergo metaplasia. Myositis ossificans is the classical example of connective tissue metaplasia, which results in the muscle actually turning into bone. Ooh, how do you move when that happens? Muscle turning into bone. Ouch! Myositis ossificans. Now that's usually when healing from a trauma. Now dysplasia is disordered cell growth. Dysplasia is usually used to describe precancerous cells, right? On your future reports, when you're rotating through the hospital, or if you actually decide to go into medicine or surgery, you're going to see various reports from pathologists from some biopsy that you're attending performed something or the other. And if you see dysplasia on there, be glad that it's not adenocarcinoma, etc. Cervical intraepithelial neoplasia represents dysplasia. Cervical intraepithelial neoplasia is a precursor lesion to cervical cancer for all those folks out there going into OB-GYN. Dysplasia often arises from long-standing pathologic hyperplasia, such as what? Such as endometrial hyperplasia, which may progress to endometrial adenocarcinoma. Fortunately, dysplasia is reversible. That's why we do screening, right? All those pap smears and whatnot. We want to catch dysplasia or metaplasia before it progresses to a malignancy. Now here's an image of a biopsy of sorts from the cervix showing cervical dysplasia. You're probably like, what the heck? I only see pink and blue. I have no idea what this is. Well, let me tell you what it is. On the left side of the image, note that the cells at the top of the squamous epithelium, for the most part, look the same. On the flip side, on the right side of the image, it's very hyperchromatic and basophilic. That means it's very blue. We don't like to see that. That's the dysplasia. Now, aplasia is the failure of cell production, or agenesis, during embryogenesis. Classic examples of agenesis include adontia or anodontia, agenesis of the corpus callosum, agenesis of the bladder, aglossia, agnathia, amelia, ear agenesis, eye agenesis, Mullerian agenesis, and the dreaded penile agenesis. Radiologists. Here is agenesis of the corpus callosum in a 1-year-old boy. Clinically, he was experiencing psychomotor retardation. We have an MR image in A and a T1 weighted image in the axial plane, T2 weighted image in the sagittal plane, and a T1 weighted image in the axial plane. What we're seeing is heterotopic gray matter bilaterally in parietal regions, hinting at the agenesis, or the lack of development, agenesis of the corpus callosum. Hypoplasia is the decrease in cell production during embryogenesis. Hypoplasia results in small organs. Hypoplasia, small organs. Classic examples of hypoplasia include streak ovaries and Turner syndrome. You got to know that. Small testes and Klinefelter syndrome. You got to know that. Small thymus and DeGeorge syndrome. Guess what? You got to know that. Small lungs as a result of oligohydramnios. You gotta know that. Small ears and fingers and harlequin type ichthyosis. You might not see that, but if you know that, A+ to you. Also, you're going to need to know all the mutations for Turner syndrome or the genetic alterations for Klinefelter syndrome, DeGeorge syndrome, etc. If I was you, I'd start making a list. What's Turner syndrome? I'll tell you off the top of my head, that's monosomy X. Klinefelter syndrome, boop, look that up. DeGeorge syndrome, that's 22q11.2, something like that. You're going to have to know these mutations. They're testing for it more and more. If you know what Klinefelter syndrome is, let me know. Figure out a way. You're smart. I believe in you. Turner syndrome, also known as congenital ovarian hypoplasia syndrome. This image shows the classic features of a patient with Turner syndrome. If you could name them, you're on the right track. Look at that broad shoulder. Wow, we made it. We finished this great lecture. Okay, awesome, A+, round of applause. There's something that I want to tell you though. You're going to be great. Happy studying. Make sure that you retain as much information as you can, because it always comes up. Whether you're on the wards, you're walking around, your friends, your family's asking you. All these things you're going to be asked. So the more you know, the more you can help people. The smarter you are. It's good to be smart, right? See you next time.